Good evening, one and all. So we are going to start the session. So on behalf of management and our beloved principal and APTA AP State Branch President, good evening to everyone and welcome to the fifth day of one-week National Online Faculty Development Program organized by ASN Pharmacy College, Tenali, AP, in association with APTA AP State Branch on artificial intelligence in drug discovery and development. Myself, Dr. D. Nagarjuna Reddy, Professor, Department of Pharmaceutical Regulatory Affairs, ASN Pharmacy College, Tenali. A part of this E-Fdp, today's topic will be delivered by our beloved resource person, and the topic is pharmacological interventions against pulmonary fibrosis, relevance to COVID-19 pandemic. So it is my immense pleasure to take part to introduce our today's resource person, Dr. Sistal Ramakrishna Garu, Chief Scientist and Chair, Department of Applied Biology, CSIR, Indian Institute of Chemical Technology, Hyderabad, India. Dr. Sistal Ramakrishna Garu did his BPharm and MPharm degrees from Andhra University, Visakhapatnam. He has taken the doctoral research at Pharmacology Division, CSIR, IICT, and was awarded PhD from Osmania University, Hyderabad in 1999. After having 3 years of each of industrial and academic experience, he joined in CSIR IICT as scientist in 2001. He is currently holding the position of Chief Scientist and Chair of Department of Applied Biology, CSIR, Indian Institute of Chemical Technology, Hyderabad. His areas of interest include pharmacological interventions targeted against inflammatory disorders and organ toxicity to fight various signaling pathways related to oxidative stress, apoptosis, and inflammation. He also been working in the area of novel drug delivery systems, particularly in the area of ligand-coupled nanostructures, nanocarriers, such as polymeric, solid lipid nanoparticles, and dendrimers for various drug targeting applications, particularly to the brain. Dr. Sistla Ramakrishna Garu has conducted around 80 projects on regulatory toxicology, pharmacokinetics, and pharmacological screening, which was sponsored by various private public stakeholders. He has published more than 180 research papers in several international journals and also authored 7 book chapters on various aspects of pharmaceutical sciences, including drug delivery systems. He is also a fellow of Telangana Academy of Sciences. He is a member of Board of Studies in Pharmacy and Pharmacy courses in several university institutions in India. So it's my pleasure, sir, to introduce about yourself. Thank you for giving this opportunity and over to you, sir.
Thank you very much, sir. First of all, I'm glad to be associated with you today. And thanks to the management of ASN College and also the principal, Dr. Venkatramana, inviting me to participate and interact with you people. Uh, it's in fact it's something like my homecoming. I was born in Tenali. I am from Tenali only. My schooling was done in Tenali, and it is something like a reconnecting myself to back to my home. I always feel like that. And if time permits, probably when I come over there towards that side, maybe Tenali, many of my personal works, I would love to visit your college and then interact with you, with the faculty and also with the students. But for today, I restrict myself the talk. And can anyone confirm whether I am audible, sir, or my audio is comfortable?
Yes, sir. You are audible, sir.
And is it okay? Or you want me to increase the voice?
Yes, sir. It's okay, sir. Your voice is
Yeah,
clear and loud, sir.
fine, fine. And then one more thing, sir. I'll be sharing it.
Yes, sir.
So entire screen allow. I hope it is visible, the presentation.
Yes, sir. Presentation is visible, sir.
Right, sir. Yeah, thank you. Then I'll go ahead. Now, this is a small topic which you have taken, and the reason why I wanted to show this presentation and talk on this topic is we all have seen the how a small virus, the particle which has no life, has caused a big havoc in the public across the globe. In fact, we were panic initially, we became a little lethargic later on, and then we suffered a lot second wave. Then all this suffering led to the discovery of new molecules. The entire thought process of scientists has changed. They started thinking in a different ways. Pharmaceutical formulators started thinking in the area of the intranasal delivery or the pulmonary deliveries, and drug discovery people started discovering new drugs or trying to identify old drugs for a specific use against COVID-19. And pharmacologists and clinical pathologists started working on the areas where this COVID-19 or the SARS-CoV-2 infection, what, what exactly it causes later on, what are the post-COVID complications, and why some people are becoming uh, certain problems they are facing it. Why some people are getting the cardiac problems? Why some people are getting the musculoskeletal problems like foot drop? Why some people are getting pulmonary fibrosis, though they are not exposed to any kind of a dust or any other kind of things, or sand or any or silica, any kind of things, why they are doing so. This led to the an understanding of the entire pathophysiology of the COVID-19, the SARS-CoV-2 infection. And that led to us, in fact, that also has led us to think in a different way. That's the reason why I thought it would be better to generally to talk about this particular aspect called the inflammation and fibrosis of the lung. Friends, in fact, when there is some pressure, when there is some kind of a no a threat, then the response of a human being will be different. He will be working very focused. If you see in case of wars, the First World War, Second World War, a lot of inventions happened. I don't know how many people have seen the movie Oppenheimer, where they have seen how the bomb explosion in Hiroshima and Nagasaki was actually taken into turn during the Second World War. Similarly, how many inventions, industrial revolutions, has happened during the First World War. So when there is some sort of a pressure, some sort of a emergency situation, the thought process of the people will change. So scientists, academicians are not exceptions. We are also have undergone the same pressure, and that led to this kind of things. And in fact, we worked on this area in 2020, April 1st onwards, for 1 year, I think till next year, March 2021. And in fact, we interacted with the industries and we have taken up the projects for them. We also helped them to position their molecule into the clinical trials. Let me let me tell about very simple things. Most of you people are maybe knowing it, but let us recapitulate what we know. When a germ, such as a virus that causes 19, when it invades our bodies, they attack and multiply. If they don't multiply, we don't get any infection. If they multiply, then RT-PCR report will detect it very early. Your CT value will be low. It it immediately catches the number of copies. That's the reason why in our RT-PCR diagnosis system in COVID, the lower the value, the more the infection. More number of virus copies are there in the body. It takes more time for clearing this virus from the body. But the response of a person to that high number may be different. Maybe I may respond very badly, very violently. I may undergo a lot of stress, cough, cardiac problems, other problems. It depends upon the inherent immune system properties. Second thing is it depends upon the other comorbidities. Some people, even when CT value is low, which means that there is a high amount of infection, you will find that they will not be having any symptoms also, but still they are positive. Very little. They may even transiently, they may feel for a few hours loss of taste, loss of smell. All these things happen during COVID, we have seen. So, what our body does is, irrespective of the response of our body, irrespective of the symptoms, our immune system starts working immediately. And it uses several tools to fight the infection. So different types of white blood cells fight the infection in different ways. And there are at least, you find three major types of the white blood cells, macrophages. They are the white blood cells. They swallow and digest germs, either dead or dying cells. And they leave behind certain parts of the invading germs, make it small pieces. Let us call them as antigens. B lymphocytes are the defensive white blood cells. They are also blood cells. They are part of blood cells. They produce antibodies that attack on these pieces that are left behind by the macrophages. T lymphocytes are another type of defensive white blood cells. They attack cells in the body that have already been infected. So B lymphocytes and T lymphocytes. B lymphocytes produce antibodies that attack the pieces of virus. So these antibodies, they attack on the pieces of the virus that are left behind. That means they attack on the antigens. These antibodies attack on antigens and then neutralize it. Whereas T lymphocytes, they attack the cells in the body that have already been infected. So when you get a vaccine, your immune system responds to the vaccine in the same way it would react to a real germ, right? That's what actually your vaccine does. Vaccine is either a part of an antigen or a piece, attenuated virus, attenuated part. So that's how your body responds to it. So let us understand what are the role of inflammatory cells. We have the natural killer cells, innate lymphoid cells, neutrophils, dendritic cells, monocytes or macrophages. These are all the inflammatory cells in our body. They all secrete. Well, for example, macrophages secrete the pro-inflammatory cytokines. Cytokines are some sort of mediators of inflammation. Pro-inflammatory means they cause inflammation. They cause inflammation. Or when inflammation is there, and their number also will be high. Dendritic cells are another kind of the inflammatory cells. Neutrophils are another kind of inflammatory cells that generate ROS and that cause the tissue damage. So when there is an infection, you find that the upregulation, that is more number of these cells in our body. Okay, so and that leads sometimes to we call it as a hyperimmune activation that causes something called the cytokine storm. This cytokine storm we have heard during COVID. If you see this picture, when a healthy lung is infected with SARS-CoV-2, the infected lung, in fact, responds in a different way. Very highly, it will respond. Hyper responsiveness will be there. That causes release of the cytokines, particularly IL-6, interleukin 6, interleukin 18, interleukin 1 beta, all these are interleukins. CCL2, CCL7, all these are all called the chemokines. And there is an increase in the IFN gamma levels. TNF alpha is an orchestrator. TNF alpha is something like a person in a group of orchestra. One person will hold a stick. No, That kind of a person is TNF alpha. TNF alpha is pro-inflammatory, it is anti-inflammatory. In certain situations, it acts as anti-inflammatory. In certain situations, it acts as a pro-inflammatory. But it orchestrates these interleukins and chemokines. So, as I told earlier, neutrophils release the elastase and myeloperoxidase, which will actually, matrix metalloproteinases. So these kind of things will actually be, no, they will be causing inflammation. In fact, okay, 1 minute. Yeah. So the clinical features of SARS-CoV-2 infection is fever. You will find if these are all they may not be there in all, but inflammation will be there, and individually all these things will cause. For example, TNF alpha plays a role in the production of fever, impaired hematopoietic role, and also it causes liver damage. And IL-1 beta is highly involved in inflammation. TNF alpha is involved in inflammation. So IL-6 is there in the inflammation. That's the reason why IL-6 has been known as a marker during the COVID-19 pandemic when we have done the uh, analysis biochemical parameters. So cytokine storm is an hyperimmune response that causes a distress called acute respiratory distress. It also, the SARS-CoV-2 infection, when the SARS-CoV-2 binds on the ACE2 receptor, as I told you, activation of neutrophils, it releases elastase, IL-1, neutrophil extracellular traps. Okay. Similarly, macrophages, activation of macrophages leads to the more of the T cell production, which will release the TNF alpha. And also macrophages release TNF alpha, IL-6 and all. So if you see, when there is activation or hyperactivation of the immune system, particularly the cells related to immune system, T cells, macrophages, neutrophils, white blood cells, they are all part of the white blood cells. When the activation occurs, you will find the release of the cytokines that cause cytokine storm, and this cytokine storm has an effect on the lung. When it causes on the lung, it causes ARDS, acute respiratory distress syndrome. It is acute. Once the virus is removed from the body, it will come back to the normal. Whereas if left untreated, that leads to a damage, an irreversible damage, and leads to maybe sometimes into fibrosis and other complications. Similarly, cardiac failure, we have seen in many of the patients that people have clots when the infection has happened. So it promotes the clots and then causes the heart failure. And similarly, acute kidney injury. All these things will happen just because the ACE2 receptors are present on all these organs, and then SARS-CoV-2 is binding on it. So the more you prevent the entry of the SARS-CoV-2, the better would be the response. So people have started using the mask. People have started using the hand sanitizers and all. These are all some of the ways to actually prevent the entry of the virus into your body. So, so the question is how to actually address this ARDS, acute respiratory distress syndrome. And during the COVID, everyone has seen, because of the ARDS only, people have a shortness of breath and their values have come down. The particular oxygen levels have come down, saturation levels. People started coughing. Doctors started administering the anti-inflammatory drugs like dexamethasone, Dexona, and these are all the things we have seen. Who will forget those days of COVID 2020? Right. So if you see the classes of immunomodulatory drugs, you find several classes. So we classified into antibodies. So tocilizumab and all these maps are one. RNA therapeutics are the mRNA vaccines, antisense oligonucleosides, and existing anti-inflammatory drugs are the corticosteroids, that is Dexona, dexamethasone. Biological DMARDs like methotrexate, NSAIDs like diclofenac sodium or any other kind of anti-inflammatory agents. And natural compounds like flavonoids, saponins, alkaloids, they are all also different classes of immunomodulating drugs. We have chosen a one small molecule, a nutraceutical molecule called the dihydrogengerone. It has an anti-inflammatory property. It has antioxidant activities, and in fact, it is a structural half structural analog of curcumin. And curcumin is a known phenolic compound isolated from the gingiva officinalis, right, rhizomes. And not only that, curcumin exhibits biological activities that support its candidacy for the anti-inflammatory. But the problem with the curcumin is that it has poor solubility and bioavailability. So dehydrogengerone is a representative of the half the chemical structure of curcumin, and it doesn't have the uh, problems such as poor solubility and poor bioavailability. It has good solubility. It is strong inflammatory, anti-inflammatory, antioxidant, and anti-cancer properties. So what we have done is, once we have purchased this, we try to see, we actually highlighted two activities. It has antioxidant, anti-inflammatory, and there are several other properties, but we are interested, Ramakrishna is interested only in these two. So our group has picked up these two properties and tried to validate in a models of in vitro assays, relevant in vitro assays. So what we have done is, we have taken the raw cells, they are called the macrophages. I told you that the macrophages are very versatile, we can use. Or we can use these to be cells, they are called lung epithelial cells, normal lung epithelial cells. Or you can take endothelial cells like pubic cells. There are two things in a lung. You will find epithelial cells and endothelial cells. And a fibrosis is called the interstitial lung disease. In between these two, you find edema. That's the reason why we call it as a ARDS. And raw cells are the mouse macrophages. They are not belong to. They don't belong to human beings. They are mouse macrophages, and easily available. So what we do is, we take these cells in the medium and we incubate with our test compound at different concentrations. And after 2 hours, we challenge with lipopolysaccharide. And this lipopolysaccharide is, you can call it as some sort of a antigen kind of a thing. So it actually stimulates the production of several cytokines. So what we do is, we take certain cells where we don't pre-treat with the dehydrogengerone, that is left kept as a blank. And the treated groups are the dehydrogengerone at three different concentrations, and we will use one standard also. So in such a cases, if you see, we have seen that IL-6 levels, IL-1 beta levels have come down significantly. So you are seeing in this graph, the longer graph is the longer one is the control one, whereas you find the remaining two are the dexamethasone. For example, dexamethasone is their LPS. This is only the LPS alone. This is the LPS alone. So that produces lot of IL-6 here. Whereas the treated compounds, if you see, our compounds are in the last phases, you will find. Use a microsprayer device, small microsprayer, and that has to go directly to the trachea, not to the esophagus. Okay. So the moment you put the needle in the mouth, you will find two ways. One is a trachea, another one is esophagus. If you want to feed the drug orally, then we will be sending it through esophagus. But whereas if you want to instill directly onto the lung, you have to send to the trachea. So what we have done is, we have taken animals and then we have grouped them. One is normal, we have not done anything. Second group of animals, we have given only LPS 5 mg per kg single dose on day one, and we didn't give any kind of a treatment. Third one is, we have given LPS and then started giving the treatment. The treatment is the dehydrogengerone at three different concentrations, right? And then at the end of the experiment, that is on the fourth day, what we have done is, we sacrificed. We have taken the blood samples, we have taken the broncho alveolar lavage fluid from the lungs you have taken, and then lung tissue has been separated out, and then lung tissue is subjected to ELISA and QRT-PCR and BALF analysis, that is the bronchoalveolar lavage fluid. In fact, that is used for the cell counting. We will be seeing it, any neutrophils are there. Similarly, hematology, the blood hematology will be done, and then these lung sample tissues were subjected to histopathology. We wanted to see whether there is inflammatory infiltration, interstitial edema. As I told you, interstitial edema is very clearly will be seen in 1 second. Hello. Yeah. Yeah. Hello. Yeah, tell me. Yeah. I am on a talk. Okay. Call it. I am on a call. Okay. I'll call you back. I'm sorry. I'm sorry. In fact, as I told you, endothelial cells and epithelial cells are there. So when there is interstitial edema in between, there is edema, there will be a thickening of the alveolar wall. It causes pulmonary congestion. A rat, for that matter, even human being also cannot take breath. It will be heavy. So you don't find exchange of oxygen. Right? All these are all the complications. So edema, as you know, is a response to the inflammation. When there is some inflammation on our body, you will find that there is swelling or the edema or accumulation of the fluid. So same thing happens in the lungs. So we wanted to see like this and then made into groups, as I told you, and then done the treatment. And on the fourth ray, when you actually open it, you will clearly find the lung LPS control. You find a lot of edema. In fact, size has increased, and then accumulation. This edema you can clearly see. Whereas this is dehydrogengiron plus LPS. This is only LPS. There is no drug. This is a normal sham control. So if you see that there is a significant effect, if you see the gross pathology of a rat lung. Similarly, if you see the histopathology level, you will find that the inflammatory score is much more in LPS control. This is the one. And these two belong to 25 mg per kg and 50 mg per kg of dehydrogengiron. And this is the normal one. So this is actually, this dose is dose dependency. It is trying to bring down up to this level. So this clearly shows that the dehydrogengiron acts as an anti-inflammatory, and also being antioxidant, it has a potential role to be taken as an inflammatory compound, and that can be used for the acute respiratory distress syndrome (ARDS). Okay, so in order to prove that, we can still use immunohistochemistry, wherein we can measure the neutrophil elastase images also. So Tenali, and these are all just supportive things. So I do not want to go deep into this, but these are all actually have been told, given to here to see that the role of all these things. For example, it's MPO level, myeloperoxidase level, which is an indicator for the oxidative stress. If you see, the oxidative stress is more in the LPS mode, whereas that stress has come down. These myeloperoxidase levels have come down here. And similarly, elastase positive cells, if you count, they are more in this. And the treatment has brought them down. Right? And the apoptotic cell death, you find more of apoptotic cell death here. And that has come down here. So these things have proven can ameliorate the acute respiratory distress syndrome that is induced by epopolysaccharide. And this, it acts by inhibition of the cytokine storm. It inhibits the oxidative stress, and it has a certain pathway. And that pathway I didn't show you. This MAP kinase pathway, MAP kinase, and then this is inflammatory pathway. MAP kinase, NF kappa B. Okay, so this MAP kinase, NF kappa B is a classical. What do we say? This is a classical, the inflammatory pathway that is followed by many of the anti-inflammatory agents. Right. Now, having proved that, and we actually have gone a little further. If this ARDS is not stopped, so it may lead to uncontrolled activation of the molecular mechanisms and causes an irreversible change in the lung tissue, which is called the fibrosis, pulmonary fibrosis. So, SARS-CoV-2 infection led to the acute respiratory distress syndrome, and during which severe fibroproliferation can occur. So, and this lead to the deposition of the extracellular matrix (ECM) by fibroblast, and they include the direct cytotoxicity to the epithelium and endothelium. So, when the deposition of the ECM causes by the fibroblast, and that include the mechanisms include direct cytotoxicity to the epithelium and endothelium. And if you see these two pictures, the upper one is a normal course. If you see the endothelial cells and then epithelial cells, right? Alveolar, these are all alveolar epithelial cells, these are all alveolar endothelial cells. So what happens during this period is you find that there is a during the SARS-CoV-2 infection, there will be an increase in the proliferation of the fibroblast to the deposition of this ECM, extracellular matrix, and also the deposition of the collagen. So that leads to the deposition of the collagen and makes the tissue very fibrous, hardened. The lung will be like a rock. So so you do not find the 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 movement, in the sense lung undergoes some expansion and compression. It is like a balloon or some kind of bellows. సో కొలిమి తిత్తిలాగా పనిచేస్తుంది. సో ఎప్పుడైతే when the elasticity is lost because of the fibrous nature, then what happens is, a person finds it very difficult in breathing. He has to breathe and he has to exhale. So both things cannot happen. Okay. So keeping this in mind, what we have done is as I told you, that if it is not addressed properly, that may lead to the fibrosis. And to tell from the pharmacology, you will find this in the pharmacology also. Transforming growth factor TGF beta is the main culprit that causes a fibrosis. So there is something which is activating TGF beta, and when TGF beta is activated, and all these things will happen. Fibroblasts, and then convert into they differentiate, they proliferate. They proliferate means they increase in number, epithelial cells and fibroblasts, and they differentiate, causing the myofibroblast, and more of the extracellular matrix will be there, and that matrix is deposited here, causing a difference between a healthy and then fibrotic lung. So there are certain genes called the certain factors like CTGF, FGF, PDGF, which will be there. Similarly, there will be inflammatory markers will be increasing, such as IL-1 beta, IL-4, IL-6, TNF alpha, IF and gamma, and vascular endothelial growth factors, transforming growth factors. All growth factors will increase over there. So, and this condition is called the fibrosis, and it is characterized by the diffused. Diffused means not concentrated in one place, in the entire lung. Alveolar inflammation will be there, extensive interstitial fibrosis will be there, and inflammatory factors will be there, fibrosis related cytokines will be there. So this IPF, idiopathic pulmonary fibrosis, leads to the high mortality, and survival rates are very low. Lung transplantation is the only way. There are no drugs. There are currently 2 drugs are there, and it is established that the TGF beta 1 is a key factor in the initiation of this pulmonary fibrosis, that promotes the proliferation and transformation of lung fibroblasts, these lung fibroblasts, and deposition of the ECM. So, though it is not understood pathogenesis, we know that people who are having suffering from this fibrosis, they are given the anti-inflammatory compounds like corticosteroids, prednisolone, they liquid, immunosuppressants are being given. The specific drugs are only two. FDA approved drugs are nintedanib and pirfenidone. There are no drugs as of now. These two drugs are having their own problem and side effects are there. Nintedanib causes the liver toxicity, whereas pirfenidone causes is a weak inhibitor. You need a very larger doses of the pirfenidone. You can check in the internet also. The doses of pirfenidone are very very high, and nintedanib is, though the doses are they, like say for example 800 or 900 mg is for pirfenidone, for whereas for nintedanib the doses are up to 100 and 200, and still they are high. But the problem with nintedanib is there is a liver damage will be there, and then gastrointestinal disturbances. So, well, this is about the definition, epidemiology, symptoms, and all. So, so let me actually quickly go how it happens here. As I told you, the platelet activation and then release of inflammatory mediators, in fact, they are the culprits. And all these white cells, actually the macrophages, T cells, neutrophils get activated, and during the activation, there is increase in the PDGF, and there is increase in the IL-1 beta, and there is increase in the TGF beta 1. When TGF beta 1 and these inflammatory mediators are increased, fibroblasts are converted into myofibroblasts, and myofibroblasts release extracellular matrix, and this extracellular matrix deposits on the lung, which causes the pulmonary fibrosis. Okay. So what we have done is we wanted to see whether this dehydrogengiron can be effective against fibrosis. So remember, whenever we wanted to do anything on the animals, we do something on the cell lines or on the in vitro assays, ensure that it is working. Then only we go for the animal models. So what we do is we have taken the IPF diseased fibroblasts cells that are available. They are commercially available, and then this is the diseased cells. We can pre-treat them with dehydrogengiron, our compound, at 3 dose levels. And after 2 hours, last time, I think in the previous experiment, we added LPS. Here, we know that the TGF beta stimulates. So, when TGF beta stimulates the fibrosis, and when fibrosis is stimulated, certain factors are increased. What we do is we can actually add the TGF beta and then see whether the certain markers are not produced or when they are produced. Obviously, when TGF beta, when the cells are not pre-treated with this DHZ, you find there is increase in the certain markers. Obviously, if the cells are actually pre-treated with DHZ, and then if you add TGF beta, and you don't find that many number of the factors, so which shows that DHZ acts as a antifibrotic. For example, there is one marker called the alpha SMA, okay, and there is another one called FN1. FN1 is called the fibronectin 1, right? And then COL3A, collagen. So all these things you find that uh, this TGF beta control is highest when 5 nanograms has been given. You find alpha small level so high. So, and on that, and if you add dexamethasone, and also if you start adding your compound DHZ, you will find actually the reduction in the levels of alpha small. So we can we can see how much of alpha-asthma has been inhibited. So LL29 cells are the disease cells wherein we can find out how much is the IC50 of DHZ, and that value happened to be 103.89, right? So if you see B to D, example B, C, D, in this B, C, D, the elevated expression of alpha-asthma, COL3A, FN1 are observed when TGF-beta alone was added. And DHZ pre-treatment has brought them down. It has lowered. Similarly, you can see that the protein expression, same thing, protein expression. This is done by PCR. That's the reason why it is given as a fold change here. The same thing, if you do it in a Western blot, you are seeing at the gene expression levels. You are seeing it in the protein levels. Genes, as you know, will actually produce the proteins. So the protein levels, you can see it in the Western blot. So the same levels we have seen it here. So it is proved that dehydrogengeron, in fact, can ameliorate, can reduce the markers related to fibrosis, right? So markers such as the fibronectin 1, FN1, COL3A, and alpha-asthma were significantly reduced when the cells are pre-treated with dehydrogengeron before stimulating the cells with the TGF beta, and TGF beta is involved in the development of the fibrosis. So keeping that in the mind, we actually have designed a small experiment, a small in vivo experiment. We have taken Sprague-Dawley rats and we have used them n is equal to 10 per group, and we have made them into different groups. So what we have done is we have done a normal control. For example, the groups are known here. At least 5 groups are there. Yeah, 5 groups are there, and each group is having 10 animals. What we have done is on day 0, we have done given single dose of bleomycin, and on the we have waited for till 14 days, and then started the oral dose of dehydrogengeron 25 mg and 50 mg per kg, and PFD is called the perfenadone, a standard drug, and we have used it 50 mg per kg. And then it means we have given on day 0, waited for 14 days. It usually takes 14 days for pulmonary fibrosis to develop in. So what we do is we assess day 7 at least to see whether the inflammation phase is there. First inflammation, then fibrosis. In this presentation, first ARDS and then fibrosis. Acute respiratory distress happens during this period, and if it is left untreated, then it fibrosis. Same rule we followed. We didn't do anything. On this stage, we given this bleomycin and then 14 days. From 15th day onwards, we started giving DHZ test compound daily single dose, and so one, two, three. 3 groups are there. 2 groups belong to dehydrogengeron at 25 mg per kg doses, and another group is perfenadone, a standard drug against fibrosis, and so 2 groups are the normal control one, another one is bleomycin control. So we sacrificed the animals on 28th. Up to 29th day we sacrificed. So before sacrifice, we usually do the lung function test. And there is something called the flex event apparatus, which can perform whether lung is functioning properly or not in a rat. That is specifically designed for rats and mice. We have that instrument, which costs somewhere around 50 lakhs or so. And we have been using it to see whether the lung function is proper or not. And for some rats, out of 10 rats, 3 are subjected to flex event, lung functional parameters, and 3 are used for the ball fluid connection, bronchoalveolar lavage fluid, and then that fluid actually it is measured for the alkaline phosphatase and then different cell count. And lung tissues, remaining 4 animals, lung tissues are collected, and part of the lung homogenate is used for the RT-qPCR, part of it is for Western blotting, immunohistochemistry, and then certain amount of the tissue has been sectioned and then stained with hematoxylin and eosin, H&E, that shows about how inflammation is happening. And some sections are actually stained with Mason's trichome, which will actually tell that is specific. This staining is specific for fibrosis. And also we do the hydroxyproline assay. Hydroxyproline is a surrogate marker for collagen. As I told you that the collagen deposition is the one which actually is the culprit. So collagen deposition, if you want to measure the collagen, we have to you have to measure the hydroxyproline. So if you see, dehydrogenone substantially improved the body weight. 28 days we are keeping it. So if you in a bleomycin control, you will find that the body weight is coming down. Whereas in groups which are treated with the dehydrogenone, you will find that the body weight is being improved. Okay. And what we have done is we have taken these uh, ball fluid and then we have measured the ALP levels, alkaline phosphatase levels, and alkaline phosphatase levels, and then count the blood count. So, we will see the WBC count. We can see the percentage neutrophil count, and also we can measure the hydroxyproline. And we have used part of the animals for the lung functional parameters. So lung functional parameters are certain parameters. For example, airway constriction, stiffness. As I told you, in pulmonary fibrosis, stiffness happens, and then and compliance will be there. Ability to stretch, that comes down, right? In case of lung cannot stretch, in case of fibrotic things, all these things we can estimate it. We will find that the total respiratory system resistance will increase, elastance will increase. All these things will increase here. Similarly, inspiratory capacity, the capacity to take up the air, that comes down, and similarly the area will come down. So in case of fibrosis, you find all these 5 markers will increase and all these 4 markers will come down. And in the animals which are treated with the test compound, these things will be reversed. All these things will come down, all these things will improve. So improvement, we say that the reversal of what you are seeing it. And these are all the parameters which are elevated in the fibrotic conditions. So this we have shown them, and one only I can show. For example, in the last one, resistance is more in case of a bleomycin rats, where rats are fibrotic, there is no treatment. Whereas if you see the perfenadone, it has come down. This is a standard drug, and these two are dehydrogenone at a dose of 20 mg per kg. This is 50 mg per kg. This 50 mg per kg is almost equivalent to the standard drug, the response. So this is how actually when we do the research, we try to see in a higher dose of dehydrogenone whether this effect, what we are seeing, good effect, positive effect, is on par with the standard drug or not. Okay, and it has shown good activity. And similarly, we have seen the levels of fibronectin, alpha small levels, and collagen A levels, and we have seen them in the particularly in the by using the RT-PCR. It's a cold chain. We are seeing it. The same thing we have seen here in the expression of genes collagen A more, whereas perfenadone has brought it back, standard drug, and 2 doses of our drug dehydrogenone has brought them back. Particularly the 50 mg per kg is comparable to perfenadone. We can stain them, and we can see the fibrotic markers. This is called the Mason's trichome staining. Mason's trichome staining, you can clearly see the difference between these two. And this is the bleomycin control, and this is perfenadone. We should expect that the blue one should come down here. Okay. This is for the inflammation, the same thing we can see. So the conclusions are that one should know that after after nearly 2 years of the COVID pandemic, we have seen that there is a significant progress in the therapeutic interventions that are directed towards the uh, lung fibrosis, lung pharmacology, particularly in case of infections, diseases, and all. And improvements are significant strides have been made in the area of vaccinology and also in the area of immunopharmacology and also on the lung pharmacology. And phytochemicals offer generally several advantages over the small molecules in terms of safety. And since they are safe, we can use them as adjuncts to the main therapy. In this present case, when we have given LPS by intratracheal administration, we could see edema in the lungs. It caused the lung inflammation or the so-called acute respiratory distress syndrome. It increases cytokine. We call it as cytokine storm, and it also increases the more and more expression of genes related to the cytokines and chemokines. And all these things are reversed when the dehydrogengeron is given at two different doses. So that has significantly shown positive effects and reduces the cytokine storm, and that is supported by hematological, biochemical, other analysis. And since we have established that the dehydrogengeron can be a good anti-inflammatory agent against ARDS, and we thought that why can't it be seen whether it can reduce the pulmonary fibrosis, whether it can reduce the mitigate the fibrotic cascade. So, as expected, dehydrogengeron exerted its antifibrotic activity by a specific pathway, and this pathway, as I told you, is out of the scope. That's why the molecular pathways are not. I'm not telling it because of no time consumption. It is called the catenin pathway. Okay, so WNT catenin pathway that we can talk little later, but remember that it causes antifibrotic effect through a specific pathway, and it can be developed as a dehydrogenation can be developed as an antifibrotic drug for a condition called the idiopathic pulmonary fibrosis, and which is an unmet medical need. So, colleagues, I think I'll be concluding at this place. And remember that this was not been possible without the, without students working. And luckily, I have the students with me. Taslim Sheikh is the one who is actually it is her work. In fact, her PhD. And Sai Balaji Anukulapati is my colleague, and Madhusudana Kuncha is another my. He is a technical officer. He is my scientist. And thank you very much for your. Hope I can answer.
Thank you, sir. Oh, once again, good evening, one and all.
Yeah, I will be
Like,
happy if there are any questions. I will be ready to take, sir.
yes, sir. If any queries are there, you can please
Yeah,
ask.
there is one question. Is pulmonary fibrosis curable? Prashu Pharma. Pulmonary fibrosis, of course, yes, it is curable to some extent and preventable also. Nintedanib causes diarrhea issues and causes appetite. The problem with nintedanib is not only nintedanib, it's gastrointestinal toxicity. As you said rightly, it causes a toxic, not only hepatotoxicity, it causes gastrointestinal toxicity. But as of now, there is no other way. Even there among you people who are interested in making a good formulation, come to me. We will work on a specific formulation which can avoid um, these commented. If you can understand why causes the gastrointestinal problems, we can avoid it. Yes. So as of now, nintedanib, there is no way we have to bear with this. Is there any alternative drugs in place of nintedanib we can use? Yes, pirfenidone is being used, and well, if dihydrogengiron, let us develop it so that we can sell it. Can you send the PPT? I have already sent it to Venkatraman. It is with them. What are the natural phytochemicals which heal this pulmonary fibrosis? I feel that a molecule, a phytochemical which has a profound activity on IL-6, particularly if it is IL-6 inhibitor and TNF alpha inhibitor, and we can try in the model and publish a good paper also. Samba Apasani, thank you. Prashu Pharma, sir, I want to work on this drug. Okay. Sonali Manvatkar, nice presentation, very informative. Thank you. Mother is suffering from pulmonary fibrosis. Yeah, I don't know what kind of medications she is taking. It usually anti-inflammatory things, and then inhalers. People use it. I don't know who is this Prashu Pharma. Can he can open up? He can interact with me. You can share, sir. You can share my email ID to him or her, so that if he has any kind of a things, I can. Yeah. Any other questions? The emotional state of mind affect immunity.
Hello, sir.
It should. In the emotional state of a mind can it actually has a bearing. In fact, that is what is the people use in homeopathy. Yes, Parash Pharma.
Yes, sir. Good evening, sir.
Good evening.
Actually, my mother is suffering from pulmonary fibrosis. So,
Yeah.
presently she's taking nintedanib.
Yeah.
Nintedanib, she's taking, sir, actually.
Mm.
So, the main thing regarding nintedanib, what I have observed from previous months, for about 6 months, she's using. So, she's getting skin rashes, she's getting diarrhea. So, all these are some of the side effects I've observed.
In fact, my suggestion would be take actually a doctor's advice for actually monitoring the liver functional parameters like ALT, ALKP, bilirubin, that would be done, and gastrointestinal things like the
Yeah,
diarrhea.
if she's taking 2 doses, she's
Yeah,
always getting this diarrhea issues and all. Now she has reduced the dose to one dose per day. So then this diarrhea issue started reducing, but her she's keeping on coughing.
yeah, that's true. But as of now, there are no other ways. This is actually nintedanib is a tyrosine kinase inhibitor. So you have to see what doctors are prescribing for the diarrhea. Is it due to the motility, increase in motility,
Previously,
or
she
is
used
it
to
due
get
to
even
the
vomiting spells.
no, no, or is it due to the killing of the bacteria that is needed, for example? Yeah,
Yes, sir. I want to work on that drug, sir. Actually,
good. I think please work on do some literature survey. What
yes, sir.
actually is responsible for the side effects?
Yes, sir.
Nintedanib formulation can be made as a blockbuster if we can prove that with the new formulations, if we can bring down the toxic effects of nintedanib, you are there in the global market.
Yes, sir.
Pharmaceutics or pharmacology?
Yes, sir. Yes, sir. I am from pharmaceutical technology. My specialization is pharmaceutical technology.
Where are you working?
Sir,
Where are you working?
presently I'm working in Aditya College, sir, Kakinada.
Aditya College is there in Kakinada.
Yes, sir. Surampalam, we say.
Yeah.
Aditya College of Pharmacy, sir.
You can meet me on 22nd. I'm there.
Okay, sir. Definitely, sir.
I'm coming, and Ravi Shankar called me for a specific
Yeah, yes, sir. Yes, sir. He's our
event.
principal, sir.
Yeah, I'm coming over there. You can meet.
Yes, sir. Definitely, I'll meet you, sir.
Right? Any persons are there here? Faculty are there or students? Only two people are active. Okay.
Okay, sir. Thank you, sir. So let's go for vote of thanks, sir. It's a very informative session, sir, from you. And I would like to extend my heartfelt gratitude, sir, from ASN College of Pharmacy on behalf of management and our Baylor principal, sir. Thank you for sparing your time, and we thank you for accepting our invitation in your busy schedule, sir. Thank you.
Thank you, sir. Thank you very much for
Thank you, sir.
inviting me for this occasion.
Thank you, sir.
So, shall I take the leave then?
Yes, sir. Yes, sir. We are
Yeah,
closing the
right.
session. Sir.
So, thanks to the management, first of all, for calling me, and also thanks to Venkatramana for interacting me so quickly.